Are you ready for our seventh acyanotic heart disease? This one's going to be the patent ductus arteriosus. So we've talked about the ductus arteriosus multiple times before, but now we're going to dedicate a whole set of slides to it. So a ductus arteriosus connects the pulmonary trunk to the aorta, allowing the lungs to be bypassed to supply the lower body with blood. And the problem here is that when the baby is born, usually the ductus arteriosus closes, but in this situation it remains open. That's why we have a congenital heart disease. So some pathophysiology. The ductus arteriosus is normally present in fetal life, but it fails to close after birth. So you have a persistent connection between the pulmonary artery and the aorta. So look what happens here. You've got the aorta linked to the pulmonary artery by the ductus arteriosus, and this is abnormal. So what happens is that you get blood flow going from the left atrium to the left ventricle, everything's fine. But when it goes to the aorta, some of it goes to the pulmonary circulation, and some of it goes to the body and systemic circulation. As a result, the oxygen content of the pulmonary artery becomes much higher than normal. Remember, the pulmonary artery actually has very low oxygenated blood, but it's going to be very high now because you're getting arterial blood from the aorta going into the pulmonary artery. So the normal way you close the ductus arteriosus is through a sharp decrease in prostaglandins and a sharp rise in arterial oxygen levels and alveolar oxygen levels. So when oxygen levels go up, the ductus arteriosus closes because that means the lung is functional. And when prostaglandins go down, you get loss of the ductus arteriosus muscle tone, you get increased ductus arteriosus muscle tone, and it contracts it down and disappears, forming the ligamentum arteriosum. So decreased prostaglandins cause increased muscle tone of the ductus arteriosus. So if you don't have a closure of the ductus arteriosus, you get a left or right shunt from the aorta to the pulmonary artery, and you get greater pressure in the pulmonic circulation and the pulmonary artery as a result. So this is actually incorrect. You have greater pressure in the pulmonic circulation and pulmonary artery. I will fix that in the presentation. The larger the size of the ductus, the greater the shunt and the worse the symptoms. So if you have a larger ductus, more blood will go from the aorta to the pulmonary artery, because what is a lower pressure system? The aorta or the pulmonary artery? Definitely the pulmonary artery. So more blood will go this way on the left or right shunt. Some signs and symptoms. The small PDA is usually asymptomatic, so it doesn't usually cause many problems because it's so small. But a large one can lead way too much blood going to the right heart and to the pulmonary circulation, and this can lead to heart failure. So excessive blood flow will be to the pulmonary circulation, not the right heart, but the pulmonary circulation, and overwhelm the lungs and cause major problems such as heart failure. You also get dyspnea with feeding, failure to thrive, and tachycardia. All of these are secondary to excessive blood flow into the lungs and more blood coming back to the left atrium and left ventricle and overloading these with blood. With a large PDA, you also get a very high risk of increased pulmonary vascular resistance. And why is that? You get excessive pulmonary vascular resistance because of so much blood going to the pulmonary circulation, causing edema and hypertension. And over time, the right ventricle can massively hypertrophy because it has to pump against this increased resistance. And over time, if the right ventricle and the pulmonary artery get hypertrophied enough or have high enough pressure, the shunt can switch and go from left, instead of from left to right, it can go right to left, and you can get cyanosis. So if you have an increased pulmonary vascular resistance and the pulmonary artery pressure is exceeding aortic pressure, the shunt will shift to right to left, and you'll get a right to left shunt and eventual cyanosis. You also get a murmur with this condition as well, and it's a continuous murmur in the left upper sternal border. Continuous meaning that it happens in systole and diastole. So let's take a quick listen to this murmur. You hear that machinery sound? It sounds like machines are working. And also it's happening throughout the entire systole and diastole. That's classic for patent ductus arteriosus. So as you notice, it sounded different in systole and diastole. And you can listen to this on your own when you look at the presentation. So now for diagnosis of patent ductus arteriosus. So chest x-ray and EKG are going to be helpful for this condition initially. A chest x-ray is going to show increased pulmonary vascular markings because of excess blood flow into the lungs. left atrial enlargement and left atrial hypertrophy because more blood flow is coming to the left side of the heart. But you can also get right-sided enlargement as well because the right side is pumping against this excessive pulmonary vascular resistance. And as always, echocardiography is a definitive diagnostic test. And treatment is indomethacin. Remember, indomethacin is a very strong NSAID, which will decrease prostaglandins. So if you have prostaglandins decreased, the PDA can close. But be really careful closing a PDA in cyanotic heart disease. You don't want to do that because that might be the only thing keeping the infant alive. If indomethacin fails, then you give surgical closure as your treatment option. So a key USMLE topic that I want you to look up on your own is fetal circulation. You can look this up in first aid, and it will tell you both how fetal circulation works and also what happens upon the first breath and what closes and how fetal circulation changes to neonatal circulation. Very important to understand PDA and congenital heart disease. Remember, the Ductus arteriosus and the ASD, the purpose of these, not ASD, but patent foramen ovale, the Ductus arteriosus and patent foramen ovale are important because they both go from right to left because the lungs aren't being used. Oxygen comes from the placenta in fetal life. Let's now talk about eisenmengers syndrome. This is a very important syndrome to know that we've been talking about in the past. Now we'll finally discuss what's exactly going on. So this is due to an acyanotic heart disease that starts out left to right that never gets repaired. And what happens is that because it's never repaired, the right heart will start getting larger because more blood is being shunted to the right side. And there will also be increased pulmonary vascular resistance over time because the blood from the right heart naturally goes to the lungs. And because of this increased resistance, you get increased pressure in the right side of the heart, and this can eventually shift the shunt from left to right to right to left. So you see right here, you can result in a right to left shunt, and this can lead to cyanosis. So if you have increased pulmonary vascular resistance and increased pressure in the right side of the heart, a right to left shunt can result. Let's see what happens here. Say we have a VSD and we get Eisenmenger syndrome. What happens is that you have the blood now, the right ventricle is much larger than the left ventricle and higher pressure, and blood's going to go to the left ventricle, and you're going to get hypooxygenated blood going to systemic circulation. And that's going to cause cyanosis in the patient that has this condition. Usually it takes a long time for this to happen, but it can happen and is very severe. So you see the large right heart causing a right ventricular pressure to be greater than left ventricular pressure, and that leads to a right to left shunt. So some common conditions that lead to Eisenmenger syndrome that you should know: VSD, PDA, ASD, and AV septal defect. We'll talk about the AV septal defect in the next video. That's also very important to know. It's another acyanotic heart disease. So signs and symptoms: you get chronic hypoxia. Why? Because you have decreased oxygen in the blood going to the body. So you get some symptoms of this. Digital clubbing. We talked about this before. If you lose the angle between your proximal nail fold and cuticle, you get digital clubbing from chronic hypoxia. Polycythemia, because hypoxemia leads to erythropoietin production in the kidney, and you get increased red blood cell mass. Hemoptysis, because of excess pulmonary blood flow and edema, causing fluid to accumulate inside of the alveoli and damage the alveoli, and you can cough up blood. You can also get a brain abscess. This is very important in congenital cyanotic heart disease, because bacteria from venous blood will not be filtered by the lungs anymore because it goes straight from right to left. And in these situations, in all cyanotic heart diseases, you can actually get a brain abscess because bacteria shunt from right to left. Same reason you can get endocarditis as well. These bacteria can build up and move over from right to left. We talked earlier about paradoxical embolism. Anytime you have a right to left shunt, you have a possibility of paradoxical embolism. Syncope, because of decreased oxygen and decreased blood flow to the brain. Exertional dyspnea, because the hypooxygenated blood cannot keep up with the demands of the body. You can also get arrhythmias because the hypoxic coronary blood flow will cause damage to the electrical fibers of the heart. So now for diagnosis. Echocardiography is definitive because it will tell you the pressures and what's going on in each individual side of the heart. Chest X-ray will show prominent pulmonary arteries and right heart enlargement because remember, the right heart and the pulmonary vascular resistance have increased, which is causing this problem, the right to left shunt now, and it's due to pulmonary hypertension. EKG will show right-sided enlargement and right axis deviation, and the treatment is medical therapy to treat the underlying cause. So you want to figure out what's exactly going on that's causing this, either VSD, ASD, AV septal defect, or PDA, and you need to treat the increased pulmonary vascular resistance with different drugs. We've got endothelium antagonists, such as bosentan. We've got prostacyclin analogs, like epoprostenol. We can even use phosphodiesterase 5 inhibitors like sildenafil. Many uses for sildenafil here. This is one of the other ones. Supplemental oxygen can also help because remember, if you give oxygen, you cause vasodilation of the pulmonary vasculature, and that will decrease pulmonary vascular resistance.